Our next guest is Delaware's U.S. Senator Chris Coons, who was elected in 2010 to fill Vice President Biden's long-term Senate seat. Since his arrival in Washington, Senator Coons has worked hard to find bipartisan solutions to issues confronting Delaware and the nation. He's really made quite a name for himself as a person who can reach across the aisle, and we really admire his efforts to be bipartisan in a very difficult environment. He's also emerged as a strong voice for job creation and the innovation economy, responsible deficit reduction, progressive social justice, and a forward-looking foreign policy. He's got some great committee assignments. He's a member of the Foreign Relations, Judiciary, Energy, and Natural Resources, and the Budget Committees. And he's really uniquely positioned to nurture American innovation and make the U.S. more competitive in the global market. Chris's background includes his time as an attorney for Delaware-based W.L. Gore & Associates, one of the 200 largest privately held companies in the United States, where he helped the company expand and create hundreds of jobs. He then spent a decade of successful leadership in Newcastle County government. Chris is a graduate of Amherst College, but interestingly earned his law degree from Yale Law School and at the same time a master's in ethics from Yale Divinity School. He also studied at the University of Nairobi in Kenya. Chris, his wife Annie, and his 3 children are friends and neighbors here in Wilmington. We greatly appreciate his support for our work here at Christiana Care, and we ask everyone to join me in welcoming Senator Coons.
Thank you very much, Tim. Thank you, Dr. Gardner, for that gracious introduction. And I am so glad that an unexpected change, it is my wife's birthday. And yes, I'll probably get some knowing chuckles in the room. I actually tried to make it a happy birthday, to make breakfast for everyone, to get the kids out the door to school, to make all the right breakfasts for everyone in the right time, to walk the dog, right? And as she left, she was muttering under her breath, "Now I know I have to live forever. If I ever died, they would starve." So my apologies for being delayed a few minutes, but it allowed me the enormous gift of hearing what was a funny and insightful, a broad-reaching, and a thoughtful address by Dr. Hood. Thank you, Dr. Hood, for really quite a powerful conversation about value. But you wrote an op-ed that I thought was insightful, positive, relevant, all the sorts of things the Senate seems to greatly need more of these days, is the ability to be all of those. And later today, you're hearing from Arkady Coleman, who is a friend and a longtime innovator and a leader in financial services here, who has led a fundamentally different model of a banking organization for many years by thinking about the customer first. The conversation you were just having, Dr. Hood, with everyone reminded me of a moment I had when I was in-house counsel at W.L. Gore. We had a CEO for a long time who was an inventor and an innovator, and like most of you, someone who was remarkably gifted at science and at understanding the natural world, had been an outstanding student and had a great capacity for doing chemical engineering in his head. But one of the things that made him a great leader was that he also had common sense. He had an unusual ability to put himself in the place of our customers. And so we had 1,000 research engineers. And once a month, we'd sit down and have the latest sort of technology display about the latest cutting-edge product, everything from implantable medical devices, the stents and cardiothoracic work we're doing at the time, to dental floss, all sorts of things. And there was a group of guys who I knew, research engineers, who were very excited about this new particular treatment. They'd figured out a way, think about painting, right? Just painting at home, cheap paintbrush you buy from, the hardware store. They'd figured out a way to spray a very, very thin coating of Teflon treated in a certain way onto every single bristle so that the bristles of the brush did this. And when you put it in the paint, instead of just glopping so that you're really only getting paint on the very outside of the brush, it held 10 times as much paint. So you were able to paint much longer with each stroke. And so in front of the assembled 500 leading science minds of this multi-billion-dollar multinational, these engineers, nervous, anxious young men, put up all sorts of graphs and charts and scanning electron photomicrographs of the surface chemistry and charts demonstrating the rheology and how this all was going to make painting different. And Bob, our CEO, sat in the back of the room, so doing that and listening. And after about 20 minutes, he raises his hand, and the two of them, somewhat trembling, say, "Yes." He said, "How's it feel?" They said, "What?" He said, "When you paint with it, you know, when you paint a wall with it, how's it feel?" They had the look on their faces that made clear they'd never painted with it. I came home that day to find my then stepfather down in the basement painting just a random spot of wall. And I said, "Why the hell are you painting this?" And he said, "To see how it feels." Sometimes it is that simple. And we are so skilled at, trained in, and educated in the science and the advancements in delivering medical care that it is very hard to remember how it feels to be scared, to be weak, to be ill, and to be a patient. And I do not mean to be offensive in suggesting that, because no one spends more time up close and personal with the human reality of illness and care than physicians and nurses. So who the heck am I to tell you a single thing about caring for those who are ill? Well, your patients are our taxpayers, are my voters. And we have a critical difference in how they interact with us. Because even today, virtually every patient in their heart loves their nurse who cares for them and deeply respects, as if God himself, their physician, who holds in his or her hands the keys, the technical interventions, the magical medicine, the newly discovered treatment. But every one of them knows that they have rights, darn it, and they get to tell their senator that he works for them. So we have a somewhat different experience with your patients. I will tell you that as I tried to leave church this Sunday morning, 5 different constituents gave me a piece of their mind. We're literally passing the peace. I'm Protestant, we're, sort of peace. So this is a moment we sort of walk around, shake hands with everyone, peace of Christ. And this woman grabs my hand, holds it, pulls me in, and goes, "I sent you a letter. You darn well better respond to it." I said, "Peace of Christ." Peace of Christ. I sat down in the back pew, and after the first 4 people were done, I've got pages of notes from this. The 5th person comes up, and I said, "Honestly, do I have a little sign over my head that says doctor's hours?" And he busted out laughing. I said, "Why are you laughing?" He said, "Because I'm a physician here to complain about malpractice." What's the good news and bad news about that? Here's the bad news about that. We're responsible for paying for what you do. And what we hear from your patients, our voters, is that they want us to pay for everything. They don't want to be denied anything at any time, anywhere. And as Dr. Laskowski, I think, insightfully commented, the HMO efforts of the 90s, which were our last serious national attempt at restraining costs, produced broad and palpable backlash in our voting public, because they don't want to be told that they have a gatekeeper between them and you. They want to be with you. They want care. They want support. They want intervention. And now, some would argue with the Affordable Care Act in some ways, we have simply replaced the HMO gatekeeper with what? The Congress of the United States. And we are spectacularly bad at saying no to anyone about anything. But those of us who are literate and numerate and have some scientific background and training and are interested in cause and effect, a few of whom happen to serve on the Budget Committee, see painfully clearly how these trend lines are going to sink the entire undertaking. The entire United States will become Greece in a relatively short matter of time if we fail to deal with this in a thoughtful and proactive way. And I don't mean to simply crib from your notes, but that is roughly what is going on. And the good news I can share with you is that dozens of us, Republicans and Democrats, have quietly, privately been meeting to say, we have to change. We have to get over where we are. We have to make some reforms to Medicare and Medicaid. We have to be willing to raise some revenue. We have a crushing federal budget problem that, in the absence of leadership in Washington, will simply crash the plane. Today, the nation of Greece is really a ward of the German state and has a math problem. It doesn't matter what leadership they have. They have a math problem that is almost unsolvable without fundamental pain and change. We don't have that problem. We have a leadership problem. And one of our core leadership problems happens to be in Washington, where, at least up until November, we refused to make hard choices. I have not soon forgotten a bracing talk that Dr. Mehmet Oz, who I know from growing up here together, gave a small group of us now 10 years ago when I was embarking in my role as county executive here on a bracing path of cost cutting, canceling popular programs, laying people off, reducing the pay of county employees, and raising taxes. I was one of about 20 from around the country who was facing what was then we thought of as hard times. This was pre-2008. And as a cardiologist, part of what he did was to help us see from a different perspective the challenges of giving your patients, my voters, our taxpayers, bad news. He handed out two hearts, one diseased, one relatively healthy, and he described the doctor-patient conversation that he often has with powerful, iconic national leaders. Think generally Bill Clinton, not violating HIPAA in any way. Just imagine someone on whom he might have operated, who comes in and says, I've had my third heart attack. Doctor, I'm brave, I'm tough, I'm willing to take whatever it takes. Tell me what I got to do. Expecting to be told about some brief and intrusive surgery, device, or medication. And when told you need to lose weight and start exercising, what do they invariably do? Get a second opinion. Our challenge is that we, the members of the Congress and the President of the United States, have the same public and the same problem. When we want to begin to rein in healthcare costs in a responsible and thoughtful way, we have to engage them in the conversation. We have to help them understand what are the options, what are the costs. And I congratulate the American College of Physicians, Christiana Care, and others who are real leaders in the healthcare field for recognizing that we need to train physicians differently, that we need to recognize and reward nurses, physicians, and healthcare professionals differently, that cost has to be part of the conversation for you. Healthcare cost is part of the conversation for us virtually every day. But our big challenge really is our patients, our taxpayers, my voters. Because at the end of the day, scientific literacy and understanding of cause and effect and cost is at an all-time high in the physician community and the nursing community, and sadly at an all-time low amongst the broad run of the general public. And an acceptance that physicians and nurses know best about the right path forward is dropping as access to information is democratizing. If you think about it, how many of your patients have come having already researched their condition on WebMD, having already gone to 3 seminars online about a variety of traditional herb treatments and tonics, and have an alternative view about exactly how they're going to treat themselves once they leave your office? This is on an accelerating curve, and it makes it harder for us to have some common consensus around path of treatment, cost, and likely outcomes. Let me mention just a few things, if I could, not to take up too much time, since I understand I am interrupting what was otherwise a wonderful flow. First, the idea of rational care and rationing care is a very thoughtful construct, and one I would urge that you share with members of the Congress. One of our biggest challenges, as I was trying to point out, is educating our public about what they don't know that you know, because you're on the other side of the tablet, the prescription form, and the diagnostic experiences that you have. The Affordable Care Act wrought fundamental changes in not providing health care access insurance coverage for the 40 million Americans who didn't have it. I do emphasize that when I talk. But most importantly, in changing the access to health care for hundreds of millions of Americans who thought they had it, but having never experienced a catastrophic health event, didn't realize that widely understood in this room insurance practices of the past 2 decades of the post-HMO period might well result in their being denied care or having reduced care or capitated care in those few moments when they really desperately needed care. Let me try that again. I find over and over the most passionate and the most active supporters of the Affordable Care Act are those folks who worked hard and played by the rules, who had employer-provided health care insurance that they thought was the gold standard, and who only upon being desperately sick themselves or having a child who was in a NICU for 1.5 years or having a parent who somehow had a pre-existing condition, only when they came across the cold spots in the pond and discovered that the rules really weren't the way they thought they were, do they become enraged, active, contact their members of Congress, and become tireless advocates for insurance reform. The mandate, which is sadly, and we'll see how the Supreme Court rules on this, about as popular as the HMO gatekeeper, the mandate was really a way to solve this problem. and to say to the insurance industry, a rational financing mechanism for health care is for everyone who is healthy to pay in advance so that you have the resources to provide care for everyone who is sick, and to pre-fund things that I think are great and good advancements in health care, whether it's wellness, whether it's preventive medicine, whether it's the providing care to seniors at home, the CMS Independence at Home demonstration that Christiana Care has just been granted. These are all about learning things that we used to know. These are all about things that make perfect sense to the average American. If you tell them that this cutting-edge demonstration that's been in place at the VA for years and that Christiana Care is about to participate in posits that if you provide health care at home for aging seniors, you can do it in a more effective and less costly way, you get heads nodding. Why? Because within a generation or two, all of us had families where the care of our seniors was provided at home. And all of us have had the subjective experience of recognizing the very human break that occurs when instead of caring for our own family members in our own home, we care for them in a highly technical, highly mechanical, highly sophisticated and more effective, but less humane intervention site. How many of us have had family members who struggled heroically against being sent to a home? How many of us have had families that were torn apart by fights over end-of-stage care? I'll close with this. Dr. Hood, I think, had a particularly insightful comment early on. One of the biggest gaps in physician perception about where there is waste in medical care versus where there is real waste in medical care has to do with malpractice. Are there needless and expensive tests that are duplicative and wasteful because of defensive medicine, because of medical malpractice? Yes, absolutely. Is that something that we can and should do something about? Yes, absolutely. But in my view, the biggest elephant in the room, or donkey in the room, I'm being bipartisan today, is end-of-life care. My step-grandmother grew up in western Wyoming, and she grew up in Wyoming at a time when it wasn't yet a state. And one of the things that she shared with us when we were young that she'd heard from some of the Native American tribes was a saying they had, which apparently sounded better in the original, which was, you haven't lived a good life until you have had a good death. From the first times I knew her, she was clear about the value and the strength of dying well and at a time of your own choosing. That is a wisdom that is very unusual in our society, and the rest of my extended family did not share. And when I've had private conversations with my friends from high school and from college who are physicians, and I named one of my twin sons for a practicing physician. I have real friends who are doctors, and I ask them about costs. It's overwhelming to me how many times I hear powerful and painful stories about hundreds of thousands of dollars in needless medical interventions delivered in the last few weeks of life because the children of someone's patient had never had the conversation, had never come together as a family, and had never come up with a plan for end-of-life care. And the physician, sometimes overridden by an ethics board, sometimes appropriately fearful of lawyers, but often because his or her patient is no longer able to make decisions for him or herself, sits there feeling helpless, knowing that the interventions that are ongoing are expensive, intrusive, disruptive, on some level even disrespectful to the wishes of the patient, yet we're engaging in them because we have a culture that does not know how to die well. 25 years ago, I spent a semester in Nairobi, as Dr. Gardner mentioned in the introduction. And as a chemistry major and a deep believer in science and modernity, I went to Kenya thinking that I might share some of my great wisdom and insight with these benighted people. The arrogance and foolishness of that worldview was soon made powerfully clear to me in my first week in a homestay where the 7-year-olds were better at milking cows and getting cassava out of the ground with a hoe than I was. Not one of them cared about my SAT scores. It was 6 months of humbling encounter with the things we knew before we became so competent and so capable that we forgot them. To me, the highlight was 2 weeks spent in the desert in north-central Kenya living with the Samburu. The Samburu are a traditional pastoralist tribe that lives the same way today that they did 10,000 years ago. Literally in dung huts in the most remote corner of a desert. And I had the experience in the very small group that I lived with of being told there was one hut I couldn't go into and couldn't know what was going on. And I sort of pressed one of the elders of the tribe repeatedly, and he finally told me this. That is for one of our great elders. His name means gaping spear wounds because he was in a fight when the British first came. He was that old. He has decided it is his time to die. He has made his death bed, and he is singing his death song. And he has sent out word to his entire family. I said, really? What will happen next? He said, they will all come. I said, how long will that take? A couple of weeks. Some live 100 or 200 miles away. And then what will happen? Then he will choose to die. When I contrasted the peace and balance of that experience with the remarkably over-technical, overly medical interventions in the last few weeks of my grandmother's life, I would choose that. Our challenge is choosing a balance between those of our lives that are extended by weeks, months, or decades by the wonderful, cutting-edge, and powerful interventions and technologies that are capable because of our skill, because of your science, because of our capabilities. But one of our biggest challenges is relearning what we have forgotten. That if we can have an honest conversation with your patients, our taxpayers, and my voters about our fear of death, if with your skill and insight, nursing and physician, if with your skill and insight and with our willingness to stand up to the consequences, we can have a healthy conversation about how to live a good life that ends with a good and respectful death, then we can make enormous progress in actually delivering value in the one piece of the whole circle of healthcare in this country which we have not yet addressed. At the end of the day, doctors aren't God. Senators aren't God. No one ever had that illusion. Our challenge is to let God be God and to do what we can within the strengths and the skills and the limits that have been set for us. Thank you.